Hi, good morning, everyone. Welcome to 144th live CMAAO weekly session. We meet here every week, sometimes alternate week, and try to bring interesting topics with interesting doctors, speakers. And today we have Dr. Glory Alexandra. She's talking on HIV infection and overview. She's a founder director for ASHA Foundation, conference committee member, International AIDS Society. She's the vice president for AIDS Society of India. She has been rewarded by the President of India as Dr. B.C. Roy Award. It's the highest award for doctors in India. She's also an International Ashoka Fellow. Ma'am, over to you for the session. We have Dr. Chong, Dr. Ravi Naidu, Dr. Akhtar Hussain, Dr. Monica, Dr. Wazi Kazi, Dr. Sajjad, and Dr. Prakash, and more people will be joining, and this session is live on social media. Over to you.
Thank you so much. Good morning to all of you. It's a pleasure to be here this morning. So can you see my slide?
Yes, ma'am.
Yes.
Absolutely.
So the topic for today's session is HIV infection and overview. The HIV response has been formulated taking into account the following SDGs: good health and well-being, education and empowerment, equality, reduction of inequities, peace, justice, and strong institutions, and global partnerships to achieve those goals. HIV continues to remain a major global public health issue and was actually occupying the top place for the last 40 years till COVID-19 came along and displaced it. HIV has claimed more than 40 million lives so far and is continuing to cause new infections and AIDS-related deaths in all the countries. As we all know, there is no cure for HIV infection. However, with access to effective prevention, diagnosis, treatment, and care, HIV infection has become a manageable chronic health condition, enabling people to live with HIV to lead long and healthy lives. So, to achieve a control over HIV, the UNAIDS has decided that by the year 2030, 95% of all people living with HIV should know their status. 95% of those who know their status should be taking the life-saving antiretroviral therapy. And 95% of those who are taking antiretroviral therapy should have achieved a suppressible or undetectable viral load. So these were the fast track targets for 2020. It was 90-90-90. 90% of people should know their status. 90% of those 90 should be on treatment, and 90% of those on treatment should have viral loads that are suppressed. And the number of global infections should be in the range of about 5 lakhs, and discrimination should be 0. As you know, this target was not achieved, and so it has been modified that by 2030, the targets are changed to 95, 95, 95, and only about 2 lakh infections globally and 0 discrimination. Where are we today with regard to achieving this target? 85% of people out of the 95% know their status. 75 out of the 95 have been started on ART, and 68% of that 75 have suppressed viral loads. So we still have a long way to go. This shows you the summary of the global HIV pandemic as of 2021. 40 million people have died and 38.4 million people are living with HIV. So this is a condition which has infected more than 75 million people over the last 4 decades. Women are higher in numbers than male, and children account for 1.7 million. In the year 2021, 1.5 billion new infections were acquired compared to the 2 lakhs, which is the target. And there were 650,000 deaths in the year 2021 from AIDS-related deaths. If you look at the geographical condition, then you can see that Africa still accounts for about 28, 29 million of the 38 million living with HIV. Asia and Pacific is the next with about 6.6 million. And then Europe is increasing and it's nearing about 4 million. And Latin America has about 2.2 million. This is just to show you the Asia and Pacific region of about 6 million infections in this part of the world. Most countries have a concentrated epidemic. India is one of them. If you look at the general community in India, the seroprevalence is low at 0.21%. That means at least 500 people have to be tested for HIV before you can find one that is positive. But there is also a concentrated epidemic occurring, which is between specific groups. And these groups are referred to as key populations. And this includes gay men and men who have sex with men, female sex workers, people who inject drugs, transgender, people who are transgender women, people who are incarcerated. These are people who have a higher risk of acquiring HIV. And this slide shows you the number of times that they are at higher risk of acquiring HIV. Over the years, if you look at this slide, you can see that the number of new infections has been tapering down, has not plateaued out, but is still tapering down. This is the number of AIDS-related deaths, which reached a peak between 2000 and 2005, and then has been coming down. If you look at India's statistics, the seroprevalence is 0.21. We have 24 lakh people living with HIV. And at 24 lakhs, we are the third highest in the world after South Africa and Nigeria. There were 62,970 new infections in the year 2021. There were 41,970 deaths in the year 2021. There has been a 46.25% reduction in new infections since 2010 and a 76% reduction in AIDS-related deaths since 2010. Every year, around 20,000 women who are HIV positive get pregnant. And we need to decrease the risk of transmission from pregnant mother to newborn child to less than 2%. But in India, currently, the final MTCT rate is around 24.2%. This is in India, again, showing the seroprevalence coming down slowly, the deaths coming down, and the new infections also coming down. But if we look at the key populations in India, in ANC, it is about 0.24. But when we look at migrants and truckers, it's about 0.51 to 0.86. But in the key populations of female sex workers, men who have sex with men, transgender and injecting drug users, as well as prisoners, the seroprevalence varies from 1.5 right up to 6%. This was for the 4 years of 2018, 1920, 2021, and 21-22 in India. The 4 years are depicted here on this graph. In the year 2018-19, 71% of 95% knew their status. By the year 2022, it became 77%, not much of an increase. 82% was started on ART, 84% in 21-22, and 72% in 21-22 had suppressed viral loads, whereas here it was about 85% in the year 21-22. What are the risk factors for HIV? Having condomless anal or vaginal sex with a person who is infected with HIV. Risk of HIV increases if there are other associated sexually transmitted diseases. Engaging in harmful use of alcohol and drugs in the context of sexual behavior. Sharing contaminated needles, syringes, and other injecting equipment for those who inject drugs. Blood transfusions and blood products, but reduced considerably over the years from about 8% in India to around less than 1% currently. And of course, any accidental needle stick injuries, which is an occupational hazard. In India, sexual route of transmission continues to be the greatest mode of transmission, followed by vertical transmission, that is from pregnant mother to newborn child. Now, when a person comes to you for HIV testing, there should be 5 C's of WHO which should be followed. One is consent. The consent need not be written, but oral consent should be available. Confidentiality, the result should remain, the whole process should remain confidential between the healthcare worker, and the patient. All HIV testing should be accompanied by pre-test counseling and post-test counseling. The test should be correct and should have more than 99% sensitivity and 98 to 99% specificity, and should have internal and external quality assurance and connection. If the patient is positive, then the patient should be connected to AR centers and other healthcare givers who help in the context of HIV. If the patient is HIV negative and he is at continued risk, he needs to be connected to the PrEP services. Today, according to WHO, rapid diagnostic tests are the way to go with regard to diagnosis of HIV. And this slide just shows you what the results will look like. If you look at the slide D, you will see that only the control has a positive bar. The rest of it is negative. So this is a correct test. This is a test in a HIV negative person. But if you look at slide E, then you can see that the bar is against HIV-2 and there is no control bar, which means that there's something technically wrong with the slide and it should be discarded. Slide C shows you a person with HIV-2 infection. Slide B, a person with HIV-1 infection, and slide A with HIV-1 and 2 infection. The commonest HIV infection in India is HIV-1. We have very few, maybe about 1 to 1.5% of people with HIV-2. HIV-2 is more common, I think, in other parts of the world like Western Africa. In order to say that a person is HIV positive, you need to have at least 3 rapid diagnostic tests to be positive using 3 different kits or 3 different antigens. And nowadays, we don't go ahead and do the Western blot test or the other tests to confirm diagnosis. The HIV antibody tests are sufficient. And the first generation test really detected the antibody, which was IgG, and that took about 8 to 12 weeks before it could be detected. Second generation, they tried to improve the process. Third generation, they use the IgM antibodies. And in the 4th generation kit now that is available, you actually look for both the P24 antigen and the antibody. So over time, the window period has reduced from about 3 months to less than a month. So if you look at this, you can see that day 0 is the day when the actual infection takes place and a person becomes infected either through the sexual route or through injecting drugs or whatever. And from day 17 to day 14, the virus begins to multiply. And if around this time a viral load test is done, it could be positive. By day 16, the P24 antigen appears and it usually develops within 1 to 8 weeks. The seroconversion begins between 7 to 21 days. And during this time, many people can develop a flu-like illness. Day 28, 95% of people will be HIV positive using the 4th generation test. And by day 90, more than 99.97% of people will develop HIV antibodies and test positive by 3 months. So as we all know, HIV has a predilection for the CD4 cells, which are part of the immune system. This is a type of white blood cell and is called the CD4 T lymphocyte or helper T cells, which help fight infection by triggering the immune system to destroy viruses, bacteria, and other germs. The CD4 cells are crucial in achieving a regulated, effective immune response to pathogens. The CD4 T cells carry out multiple functions, ranging from activation of the cells of the innate immune system, B lymphocytes, cytotoxic T cells, as well as non-immune cells, which also play a critical role in the suppression of the immune reaction. So what happens is the virus approaches the CD4 cell and fuses with the CD4 receptor. Using its CD4 receptor, it fuses with the host cell and attaches itself. And these CD4 cells are found on lymphocytes, monocytes, macrophages, dendritic cells, etc. Now, for it to be pulled into the CD4 cell, it also needs a co-receptor, which can be CXCR4 or CCR5. CCR5 is the major receptor that is present in people. The viral DNA then enters the host cell, and the viral RNA then enters the host cell and forms viral DNA. And for the viral RNA to be converted to viral DNA, it requires an enzyme called reverse transcriptase, which it produces. The virus DNA then moves across the cell into the nucleus and gets integrated into the DNA of the host cell. And for this, an enzyme is needed called integrase, which causes integration of the viral DNA into the host DNA. And then once that happens, new viruses are beginning to be produced. And these are viral proteins, which then come together to form immature virions. And these, over a period of time, become mature. And for the immature viruses to become mature, we need an enzyme which is produced by the virus called protease. And the new viruses, when they're mature, they reach the surface of the CD4 cell and leave the cell through the process of budding and infect other cells. This basically is the life cycle of the HIV virus. And I'm mentioning it here because of the importance of ART, which actually acts at 3 levels to kill the virus and prevent the replication from taking place. So this is step 1, where the virus attaches to the host cell and it needs those co-receptors, CCR5 or CXCR4. This is important in the context of cure, and that's why I'm mentioning it. Once the virus enters, it is converted from viral DNA, RNA to viral DNA and requires reverse transcriptase. Integrated into the host DNA requires integrase, becomes mature viruses, requires protease, and then leaves the cell. So the drugs that are currently available for HIV, called antiretroviral drugs, acts at any one of these 3 levels. They either inhibit reverse transcriptase, they inhibit integrase, or they inhibit protease. So these are the 2 most important tests for people who are living with HIV. The normal CD4 count is between 500 to 1,500 cells. And viral load, they are different with different sensitivity. In India, we have viral loads that can detect up to 35 copies of viruses per cc of blood. These are the 4 stages of HIV, clinical stages. Won't spend too much time on it because of the change in the guidelines. But initially, the person who has a CD4 count of more than 500 may not have any symptoms except possibly a few enlarged lymph nodes. At stage 2, the CD4 count will be between 200 and 500, and the patient can have early symptoms. They could be recurrent oral ulcers, there could be some skin reactions, there could be some level of moderate weight loss. In stage 3, where the CD4 count is between 250 to 200, the patient becomes sicker, can have unexplained fever, chronic diarrhea, severe weight loss, and other opportunistic infections. And stage 4 is where the CD4 is less than 50. Patient can have neurological manifestations, extrapulmonary TB, MAC infection, cancer, and be really sick. Now we have advanced HIV infection where adults, adolescents, and children 5 years and older, if they have a CD4 count less than 200, or if they are in WHO clinical stage 3 or 4, they are referred to as advanced HIV infection. And all children living with HIV below 5 years being diagnosed for the first time should be considered as having advanced disease. This is just to show you how some of the opportunistic infections occur at which level of the CD4 count. ART, antiretroviral therapy, it came into being in probably early 90s, 1994, and became available in India around 2002 to 2004. Antiretroviral therapy is the game changer in the control of HIV infection. Please remember that antiretroviral therapy does not cure HIV. It only inhibits the efficient replication of the virus and reduces the viremia to undetectable levels, thereby causing slowing of progression of the disease, fewer opportunistic infections. Patients feel healthier and lead more productive lives. They look healthy, and this helps to reduce the stigma and discrimination in the community. ART has transformed HIV from a virtual death sentence to a chronic, manageable illness. The treatment is lifelong. This is very important. The patient has to take the treatment lifelong. This is very difficult. For us to take a course of antibiotics for 7 to 10 days is difficult. For them to take this treatment lifelong is quite difficult. Not only that, it requires more than 95% adherence to prevent drug resistance. This is there, of course, with the older drugs that were available. With the newer drugs that are currently available, even more than 80% drug adherence may be adequate, but we can't tell the patient there. So we stress on more than 95% adherence. Adherence counseling is a must, and patient requires at least 2 to 3 sessions before we start the patient on treatment. Ideally, it helps if there is a treatment buddy who can supervise that the patient is taking his treatment regularly. This would be only if the patient agrees. And most importantly, the patient should be prepared and willing to start ART. What are the goals of therapy? The clinical goal is to prolong life and improve quality of life. The virological goal is to suppress it to undetectable levels. Immunological goal is to cause an immune reconstitution that is both quantitative and qualitative. Therapeutic goal to give drugs which are effective, at the same time maintaining good drugs for future options. And preventive goal is to reduce the HIV transmission in the community by suppressing the viral load. So these are the drugs that are currently available. So as I said, there are 3 groups of drugs actually. The drugs which inhibit reverse transcriptase, in that there are 2 sets, the nucleoside and the non-nucleoside drugs. They are referred to as NRTIs and NNRTIs. NRTIs because they have a nucleoside ring in their pharmacological structure. Nucleotides if they have a nucleotide ring in their pharmacological structure. Non-nucleoside where they don't have that ring. And so these are the drugs that are currently available. And they act at that first level of stopping the conversion of viral RNA to viral DNA. Protease inhibitors prevent the maturation of the virions to mature viruses, and these are the drugs that are available. And non-nucleoside, we have nevirapine and efavirenz. This is what was being used for a long, long time in India and all over the world till around 2012, 13, 14. And these are non-nucleoside drugs. And integrase, which have come into being more recently, there are 5 drugs currently: raltegravir, elbitagravir, dolutegravir, bictegravir, and cabotegravir. And then the entry inhibitors, post-attachment entry inhibitors. The protease requires PI boosters like ritonavir or cobicistat. So when you start a patient on treatment, you choose 2 drugs from this NRTI group. And one of those drugs has to be lamivudine or emtricitabine, but not both. Then you choose one of the other drugs, which could be tenofovir, diisopropyl, or alafenamide, TAF as we call it, zidovudine or abacavir. And then you choose one drug from the non-nucleoside group, which is usually efavirenz. So for many, many years, patients were on these drugs. And then if they developed resistance, we used to move to the second line of treatment, which was the protease inhibitors, which were quite expensive and which required more tablets. But once integrase came into being, then instead of efavirenz, it was a reverse transcriptase nucleoside-nucleotide combination along with an integrase combination. For HIV, you cannot give one drug. You have to give a minimum of 3 drugs, just like you do for TB. In HIV, if you give a single drug, patient develops resistance very fast. So this shows you the site of where the various drugs act. These are the CCR5 antagonists. This is the fusion inhibitor. This is where the reverse transcriptase acts. This is where integrase inhibitors act. And this is where the protease inhibitors act. I told you about the principle also. This shows you the ART timeline over the years as new drugs got developed for the treatment of HIV. The first drugs which were developed early were very toxic, had a lot of side effects, and had both early and late side effects, were very difficult to tolerate. Then it improved considerably, but did not fully go away. But now with the drugs that are available, they are more tolerable, and it is easier for patients to take them. So over the years, there were different types of regimes, guidelines suggested by WHO. One was that you start the patient on treatment only when the CD4 is below 200. So even if you have a patient who comes to you, test is positive, he has a CD4 of 800 cells, you watch the patient till the CD4 falls. And then they realize that that's a little difficult because the patient has a viral load and he can continue to transmit the infection in the community. And CD4, so they hiked it up to below 350, and then it became 500. But then now the current policy is test and treat. That the minute you diagnose a patient as HIV positive, you can start treatment of the patient instead of waiting to see what is, irrespective of what the CD4 count is. And this is because of 3 trials that realized that the test and treat policy was the best way to go. One was the HIV Prevention Trial Network Trial 052, which was done among discordant couples, where they gave one group of discordant couples started ART early, and the other group, they delayed the ART, and they found that there was a 93% reduction in transmission in discordant couples where the treatment was started early. So definitely this had a public health benefit. And then when we look at the START and Temprano studies, START is the strategic timing of ART, and Temprano study is also done in individuals where the 2 groups, ART was started early in one group with normal CD4 counts, and in the other group, ART was delayed till the CD4 fell. And they found that here also patient had a much better quality of life. Morbidity was reduced considerably, and morbidity and mortality was reduced considerably, and it definitely had individual health benefit. So in view of the public and the individual health benefit, the test and treat policy came into being, and that is what we were doing for all the patients. Then over the years, this group of drugs called the INSTI drugs or integrase inhibitor drugs were developed, and this was these were the drugs that I mentioned earlier: raltegravir, dolutegravir, elbitagravir, cabotegravir, and bictegravir. As you can see, these drugs have a much stronger antiviral activity, as seen in the elongated blue bars compared to the other drugs. And soon, because of the fact that they were quite efficient, they caused rapid viral suppression, they were very tolerable, they had a very high genetic barrier of resistance, CD4 recovery was quick, and they had a lower rate of treatment discontinuation because they were better tolerable. It became the first line of treatment in HIV, and all the other drugs like efavirenz and the protease inhibitors were discontinued, and most patients now, according to WHO guideline, you start the patient on INSTI as the first line of treatment. These were the various studies that we have done over the years comparing the INSTI drugs to other drugs that were already there, and they found that in all these studies, the INSTI drugs were either non-inferior or superior to the current regimes that were available. So the guideline changed, and patients who were on tenofovir, lamivudine, efavirenz for years, if they had a viral load that was undetectable, it showed that they were sensitive to all the drugs. The efavirenz was replaced by dolutegravir or bictegravir. And in adolescence, pregnancy, this was done in all cases except in children between 3 to 10 years, where abacavir was given instead of tenofovir, because tenofovir can cause kidney problems, and more importantly, bone mineral reduction in bone mineral density, which you didn't want to happen in a growing child. IRIS, again, after starting ART, especially in people who had very low viral load, very low CD4 counts, they could develop worsening of signs and symptoms due to development of, occult infections, which became clinical, or they just developed high fever with no underlying cause due to an inflammatory response by a reinvigorated immune system. Now that we are starting ART at any level of CD4, we see less of IRIS except in those who have advanced HIV. These are some of the side effects of the drugs that are available, just for your information. Chronic kidney disease is something that we have to watch out for, and decrease in bone mineral density, definitely in patients who are on tenofovir. And abacavir, they have 4 to 5% can have hypersensitivity reactions because of the presence of HLA-G B5701. So every patient before being started on abacavir has to be tested for this. TTG, though it shows hepatotoxicity, skin reactions, etc., we don't say much of this in clinical practice, really. So once a diagnosis is made, counseling is done, you assess the patient, you talk to him about ART, you do all the basic lab time testing, do 3 to 4 counseling sessions, make sure that the patient has understood, and then you start him on treatment. And then the treatment is continued lifelong with regular follow-up. These are some of the mutations that can occur as a result of the various drugs. If the patient is not regular with treatment, then they can develop resistant mutations, and these resistant mutations can then confer resistance to the drug. So just to give you an idea about some of the drugs, mutations that can be diagnosed. The most important thing to remember is this new concept of undetectable is equal to untransmittable. So if a patient is on ART and his viral load has become undetectable, then that patient will not transmit HIV to an uninfected person, even if he has undetected sexual intercourse with that patient. So this is a big deal. And it's very important that all patients be started on antiretroviral therapy as soon as possible once the diagnosis is made, so that the viral loads are suppressed and this disease is not transmitted in the community. So we refer to this as TAPS, treatment as prevention. So by treating the patient, suppressing his viral load, the risk of transmission to others in the community does not happen. Just a slide about routes of transmission in children. This is specifically for India, where about 90% of children below the age of 15 who are living with HIV have actually got it from mother to child transmission. When the mother is HIV positive and pregnant, she has a 45% risk of transmission in breastfeeding population in India during the pregnancy itself, during labor and delivery, or during breastfeeding. This is just a human interest story that I wanted to talk to you about. This is about a family. This picture was taken in the year 2000, 23 years ago. Happy family of father, mother, and 2 children. The father brought the disease into the family. He infected the wife, and the wife became pregnant. She infected both the children. And here you see the picture of all 4 of them with a child who's about 3 years old and the elder one who's about 5 years old. In the year 2003, the 3-year-old child died, and about 9 months later, from fulminant septicemia, and about 9 months later, the mother died from a CNS lymphoma. So only the father and the elder sister were left. The elder sister was under our care. We started her on ART. We supported her for education and nutrition. She grew up into a beautiful girl, and about 3 years ago, she got married to another HIV positive. And it was an arranged marriage. Both of them had undetectable viral loads. She became pregnant and she delivered a beautiful child that is HIV negative and is about 2 years old today. So the first generation, the second generation, and with the third generation, the infection stops. So you can see how effective ART is, and how if it's taken regularly without a break, it can completely eliminate mother-to-child transmission. And there are many countries in the world which have actually eliminated mother-to-child transmission. India still has some way to go. What has India's contribution been to this ART? After the patent period in foreign countries and the developed countries which developed these drugs got over, then India was able to generically produce these drugs at a fraction of the cost. And today, India supplies 92% of the world's requirement of ART, not only to India and African countries, but also to Europe and to the Caribbean countries. India was a country which developed fixed dose combinations and single tablet regimes. So all 3 drugs are present in the fixed dose in 1 tablet. And you need to take this tablet just once a day. It's made it so easy. Instead of taking 5 to 6 tablets per day for HIV, you just need to take the 1 tablet which contains tenofovir, lamivudine, and a DTG or dolutegravir, or abacavir, lamivudine, dolutegravir. So, or you can give TAF, emtricitabine, and DTG. DTG is the short form for dolutegravir. 1 tablet a day is easy to use. It's easy to procure and maintain stocks. Compliance for the patient improves, and the chances of drug resistance reduces because they are taking all the 3 drugs in the same tablet. So this is what I spoke to you about oral therapy. Now we are even looking at 2 drug treatments in patients who have had undetectable viral loads on 3 drugs and are on a DTG-based regime. When the viral load is suppressed, you can even consider changing them to two drugs such as DTG and lamivudine. Or even in patients who have very low viral loads at the onset, you can consider giving two drugs. This we could never do earlier on in the epidemic. Now, injectable ART is also available. We are looking at two, cabotegravir, which is an integrase inhibitor or INSTI drug, and rilpivirine, which is under the same category as NNRTI like nevirapine and efavirenz, but it is injectable. And these drugs are now also available for the treatment of HIV. The injectable drugs, actually, you start the patient on oral therapy, and once the viral load becomes undetectable, you can change to the injectable form of the drug, and it's effective even when given once in 2 months. A word about pre-exposure prophylaxis is pre-exposure prophylaxis, or PrEP as we call it for short, is when people do not have HIV but are at risk of getting HIV, take HIV medicine every day to prevent HIV infection. PrEP is used by people without HIV, but where they have the risk of being exposed to HIV through sex or injection drug use. This would include discordant couples, female sex workers, key populations, etc. The drugs that have been approved are tenofovir and emtricitabine. Now, injection cabotegravir is also being studies are going on for PrEP use, and I'm not sure yet if it has been approved. Then you have the on-demand PrEP, where you take 2 pills 2 to 24 hours before having sexual contact and continue the tablet for 2 days after the sexual contact, and then you can stop the tablet. So you're taking it only on demand. So these are pre-exposure drugs. And these are several studies that have been done to show that when you give PrEP in people who are at risk of acquiring HIV but are not HIV positive, it has quite significant reduction in acquiring HIV, as these various studies have shown, especially the ones in women, there was some problem. They were not very adherent to the drugs, and therefore, if you look here, you will find that the efficacy is quite low. One note about PEP, don't have too much time, so just saying that the same drugs that we are using for the treatment of HIV infection can also be used for post-exposure prophylaxis. One word on TB and HIV, because the two are so correlated and interrelated. It is the most common opportunistic infection in India. It's the leading cause of death in people living with HIV. Pulmonary TB remains the commonest form, and it is occurring either by reactivation of a latent infection or a newly acquired infection. It increases the risk of TB progression. It increases the rate of TB progression. TB may speed the progression of HIV disease. And by starting the patient on ART, the incidence of TB can be reduced. Therefore, all people with TB should be tested for HIV, and all people with HIV should be tested for TB. The incidence of HIV infection in persons with TB is around 5%. The LAMP test is a test which detects this antigen called lipoarabinomannan, or LAM, which is present in the urine, and is an antigen which is located in the cell walls of people with TB, and is present only in people with active TB disease, and especially in those with immunosuppression from any cause, but also from HIV. This is a simple dipstick test, like a pregnancy test. It has a low sensitivity, but still is useful in those cases where you are not able to make a diagnosis of HIV by any other method. Isoniazid preventive therapy is the risk of developing TB is so high. Once you've ruled out TB in a person with HIV, you could consider giving INH for about 300 milligrams a day for about 6 months. It decreases the risk of developing TB by about 33%. And this was part of our Indian NACO program for quite a while. Always keep in mind the non-communicable diseases also. As patients are living longer and growing older, we have to also look at hypertension, ischemic heart disease, cardiomyopathies, hyperlipidemias, diabetes, stroke, cancers, and also at their mental health. So we should not ignore this aspect of patient care. COVID-19 and HIV, COVID affected HIV adversely. There was a decrease in testing and counseling services. There was decrease in access to ART. There was decrease in follow-up. The pros were that you started teleconsultation and online consultation and found that it was quite effective. We could do counseling on video. And also for self-testing patients now, self-testing in HIV has also become a thing. And we could give the pre-test counseling and also a video demonstration of how to do the test. And there was one study which was conducted in India during this period. So these were some of the pros. Generally, if a patient was on ART, doing well, had no comorbidities, had good viral loads, had good CD4 counts and suppressed viral load, then even if he developed HIV, the COVID, he did very well. But in patients who required hospital admission, the mortality from COVID-19 was higher among people living with HIV than the general population, especially if it was a male gender, if they were in the age group of 65 to 75 years, had a CD4 count of less than 200, RNA count, viral load count of more than 1,000 copies, and if they had any other comorbidities like high diabetes, hypertension, or chronic liver disease. Vaccines, 40 years into the epidemic, and we still don't have a vaccine for HIV. Research has been going on since the late 1980s. Vaccine would be the best solution to achieve the targets that we want and for this disease to be taken care of. But these vaccines are all dependent on antibody formation, and the virus mutates rapidly, and the antibodies may not be effective for the new mutations. So that is one of the reasons. There are different subtypes in different parts of the world. Asia, India has the C subtype. In the Western world, it's the B subtype. And because of the genetic diversity of HIV, it's not very easy for vaccine production. Coming to cure, there are a handful of patients who have been cured of HIV. These are patients who actually had, the first patient who had HIV developed leukemia, and he was given a bone marrow transplant from a donor who happened to have a CCR5 delta 32 mutation, which prevents the virus from attaching to the CD4 cell. And after that, for all patients who had HIV and leukemia in the developed world, donors were provided for stem cell transplants who also had this mutation, and this therefore killed the HIV. And all of these patients, one of them died because of a remission of exacerbation of the leukemia. The remaining 5 are alive and doing well, and they are not on ART. Immune modulating therapies were also tried, but this again is a very expensive mode of treatment. Post-treatment controllers, this is part of the Visconti study where there are a whole bunch of people who were started on treatment and who stopped and received a lot of drugs and who over the period of time and stopped treatment for one reason or the other, and yet their viral loads did not increase. So studies are going on this to see how this could help us in getting a cure that is less expensive. Thank you for your attention.
Thank you. That's a very good session and a very informative session. And I think it's an eye-opener for a lot of patients and the relatives and the audience where we can see that over a generation, the HIV can be completely removed from the body. I welcome all the members of CMAAO over here, and I would invite Dr. Chong to, address the session.
Thank you very much, Saurabh. And thank you, Dr. Glory, for that wonderful presentation. I mean, it was really a good update on a scourge that we had sometimes tend to forget if we are not actively in the space of HIV, treating HIV patients. In Singapore, for example, most of it is done by our CDC. So we hardly get to see any of these patients outside of the CDC space. But I've actually diagnosed 2 patients with HIV here, and both of them are well and alive after, I believe now 2 decades at least. And a lot of our patients here in Singapore get the HIV drugs not from India, but from Thailand. Thailand is another source. And in Singapore, I think right now the cost of HIV treatment from Thailand, the fixed dose treatments, are about maybe 150 US a month, thereabouts, 150 to 200 US a month. and very reasonable. I mean, in our local context, meaning, in terms of affordability, and really we have converted HIV to a life-threatening
Chronic
death
manifestation.
sentence to a chronic disease, really, like hypertension and diabetes. And thank you very much. I open the questions to the floor, and Dr. Akhtar, you have some questions?
Hi, good morning, Chong, and thank you very much, Gauri. Excellent overall presentation. And you, in fact, you cover almost everything. We don't have the question more than my comment and experience in our setup in South Africa. You mentioned 2030 management to achieve 95%. I agree with you. In South Africa, what we do 2030, 99% achievement for reduction of the disease of HIV/AIDS. What we do, point of care, we make sure we screen diabetic hypertension, TB, and the vaccination for the children. So we also included that people must know I got high blood pressure, I got diabetes. So the point of care, we make sure the 99% people who come to the clinic, they get screened. That's how we are achieving about 95, 96% at the moment. And previously, before COVID, we were around 70, 75%. So it's progressing well, but COVID-19 did damage. And the PMTCT program in South Africa, initially we had 32% mortality, morbidity, and transmission rate. Some of the provinces we had about 40%, 42%. Now, after mandatory testing for all the pregnant mother and put them on treatment, we achieve now in a hospital setup and clinic setup is less than 1%, but overall is still less than 5%. Those who are escaping from the crack, migrant, displaced people, unwanted pregnancy, those are the cases we are facing now. Also, this is really great help on PMTCT and management, that PCP pneumonia, we used to sign every day 5 to 10 baby dying every day. Now we hardly see, we forgot about PCP pneumonia. The other issue, yeah.
No, please go ahead.
The other issue you already mentioned, FDC, that is the great help all over the Africa, single dose, and we are hoping vaccine will make more easy monthly treatment, 1 dose treatment for the month. Otherwise, the compliance is challenged. I need to also, tuberculosis, we don't start treatment anyone without screening TB, and at least we delay 2 weeks. As you mentioned, Irish is the biggest problem we had. And especially we had a problem with a pregnant mother who were not screened properly, and we have lost a lot of pregnant mother, maternal and death. Birth PCR we do within 24 hours at birth. Just like to know circumcision in India, what is the outcome on that and your experience? And sugar daddy meat, Africa, around African country, that myth is still there. Sugar daddy who feel or they believe that if you have a sex with the younger girls, it will be cured. So I need your experience. Thank you very much.
So thank you, Dr. Akhtar. Coming to PMTCT, in India there are 27 million pregnancies every year. That's almost like the population of a small country. And hidden among these 27 million are 21,000 women who are HIV positive and pregnant. So it's very difficult for us to access all of these women. But if you look in the private sector, we see that it's very easy. Like I myself have treated about 1,200 women who were HIV positive and pregnant. And from the year 2013 till now, I haven't had a single HIV positive baby. So it's very effective ART and it's doable. But for us, the problem is that in this very wide, maternity pregnancy rate that we have to find all of them. And many of them may not come to a hospital even for one antenatal checkup. But all those who do come to the hospital are identified, but you lose them along the cascade of services. Now, coming to VMMC, which is voluntary medical male circumcision, it's not a guideline in India. Abroad, especially in especially in African countries, and I think there are about 14 priority countries where VMMC is a part of the guideline, where it is that if a female is HIV positive, her chances of transmitting HIV to a male becomes less if that male has had a circumcision, because the surface area that is exposed to the virus is reduced considerably, and it decreases the risk of transmission by about 60%. So I know that it's one of the prevention strategies in Africa, but it's not a prevention strategy yet in India. And sugar daddy, that used to be a myth. It's still part of the myth and misconceptions that are there with HIV/AIDS. We always know that when an older woman marries older man marries a much younger woman, then and if he's HIV positive, then the risk of her acquiring HIV is much higher because of the immaturity in her, in the cervix and uterus and vagina. It is still not fully developed, and the risk of abrasions is high, and they can pick up HIV very easily. And there's always a level of inequality in HIV all over the world when you look at men and women. Women are more the childbearers and the carers. They are the last ones to go for medical support or healthcare. They go when they really need it. So that's always been an issue all over the world.
Dr. Alexander, there is a question from the audience in the internet. How accurate are the in-home HIV tests? And the second question is, how common are the false negative and the false positive?
So HIV home tests, these are new concepts in India. This is referred to as self-testing in HIV. And these are actually second generation and third generation tests. They are not fourth generation tests. And you can use either the saliva or a finger prick to do the test. Their specificity and sensitivity is much lower than what you would get in a healthcare setup. It would be in the range of actually about 80 to 90%. And because we are doing just the first and second generation tests currently for HIV self-testing, it is a good concept because we are still not able to achieve that target of 95%. And usually the last 10% to achieve is because they belong to the most vulnerable populations. And vulnerable populations, like key populations, will not come into our healthcare setup to get tested because of the issue of confidentiality. So it's easier for them to get tested at home and to receive advice on the phone and support from a healthcare worker. So those are the two things. Self-testing is a good way to go, and it will spread definitely in India, and it will become one of the guidelines in the future. And second is, but in terms of accuracy, it's not very accurate compared to the tests that are available in a healthcare setup. But if you get one test positive, then immediately you have to come to a healthcare setup for repeat testing and doing all the 3 tests and all of that. But it helps to increase the spread of HIV testing in a country. And during COVID time, there was a study done in India, and they found that 5% of all those who self-tested with support online, 5% of them were positive. So self-testing tends to show an increased number of HIV positivity.
Any other questions from the floor?
I think Dr. Monica, can you go ahead?
Yeah, so Dr. Glory, first of all, I have to say, fantastic. I agree with Dr. Chong when he says that for those of us who don't practice in this space, your summary was eloquent. It was very thorough. and really brought us, I think, in the last couple of decades, far, far ahead from where our basic training was in this process. And I think we're
Thank
all
you.
acutely aware, thank you, of the post-exposure prophylaxis. So that's kind of where maybe the space overlaps with where we are. But what you just said, I wanted to highlight, I don't know if it's more of a comment rather than a question, was looking at how pandemic really raised the awareness of infectious disease, transmittability, at-home testing. Do you feel that even though we know that the 90-90-90 target of 2020 was not achieved, do you think that the pandemic raised awareness to a level, whether it be at-home testing, virtual access to healthcare? Do you think that these are some of the things that can address some of the barriers that led to not being able to achieve 90-90-90? And how do we step forward globally, or what do you think are the critical steps to achieve the 95-95-95 of 2030?
Like I said, I think it's the last 10-15% who are the most difficult to access because they belong to the most vulnerable section of society. And for them, I think self-testing would be a good option. Several studies have shown that if they are diagnosed HIV positive, they do not harm themselves or do not commit suicide. You know, that was one big worry with regard to self-testing. The other one really is the undetectable is equal to untransmittable. You know, people know that if you take ART regularly and you take ART now, it's just one single tablet at the same time every day for the rest of your life. And you become undetectable, then you cannot transmit the infection, even if you have unprotected sexual contact. So I think that's another game changer. The game changer for HIV has been really ART, first of all, insti-drugs second, and self-testing, and this undetectable is equal to untransmittable, because we have publicized that in the HIV space so much, so people know that if I take this, I can live a normal life and the kind of life that I want to live. And it's just that I have to be regular on ART. And so that has really been publicized in the HIV space. And we have a lot of people we hope will be more amenable to coming for treatment. There's been so much of improvement. Those toxic drugs have now become one single drug. From 10 to 12 tablets, it's one single tablet. From HIV testing, it's become self-testing, one tablet a day. You need to see a doc just once in 6 months if you're doing well, just twice a year. So all of these have helped to make it more amenable for patients to come forward and get treated. Of course, you have the urban-rural divide. We need to work on that. And so I think we're going in the right direction. Of course, the best would be if we have a vaccine.
Yes.
But somehow in 40 years, we haven't got one yet.
Dr. Glory, I'm just curious, what's the average cost of the ART in India?
So it's around 1,000 rupees for a TLD combination, which works out to how many dollars is that? Divide by 85, 82. That's for a month. It's very cheap. And for organizations like ours, which are registered as charitable trusts, we get almost a 70% discount in the cost of our ART. So we are getting it for like 450 rupees, a 1 month's course of
That's
ART,
12,
which is just like $3 or $4 a month.
Yeah. Excellent. Excellent. Wow. And I think that's also another game changer, isn't it? The low cost of ART.
Yes.
Compared to even at the lowest levels, it can be accessible to a lot of people, a huge swaths of the population.
And in India, the government gives the ART free of cost in the public sector.
Excellent.
Dr. Chong, can I come in?
Yes, please.
Yeah, thank you. Thank you very much. I agree all this. What happened in our environment, stigma and discrimination is still severe. people are dying without treatment because of the stigma and discrimination. And then health system also need to be changed. We started with the vertical program. That caused problem because that is a specialized clinic. People know these patients are going to that clinic is HIV clinic. So that caused a lot of problem. We came up with a different strategy during 1990 to achieve. So we made it horizontal clinics. Everyone, whether it's an orthopedic clinic or hematology clinic or surgical, medical, outpatient, frontline, option gynae, everyone need to be tested from point of care. And that helped a lot. So the same patients are sitting in the queue and then don't know who is positive, who is negative, but they're going to get tested. So that was very tough to accept by the people, other department, because we are more compartmental type of management, like ENT guys, they don't want to see non-ENT patient, but we push it on the front line, and that helped a lot for our achievement. Thank you, Chong.
Thank you. Thank you so much. Can I make a comment? Uh, Actually, stigma today, the way it is in most of our families, it's only if it's a young unmarried male, then only he knows that he's positive. He doesn't tell the rest of the world about it. Or if there's a husband and wife who are positive, only they know. Their children and the extended family does not know. In HIV, the stigma, because they all look so well, they're contributing members of the society, and they don't, the world doesn't need to know that they're HIV positive. That is one of the strategies for decreasing the stigma and discrimination. But I also think that in key populations, there is a lot of stigma and discrimination. And there is also, in a person who's HIV positive, there's a lot of self-stigma, especially if you're a female and you're a sex worker and you're a HIV positive. That's triple stigma. So compared to how it used to, and against self, more than others being stigmatized towards you. The other thing is, over the years, stigma has reduced to some extent, but it's not completely gone. So that zero stigma and discrimination, which is one of the targets for 95, for 2030, I'm not sure how far we'll get with that. And especially in India, we are a very stigmatizing society. And I agree with you, we made a mistake by going vertical with management of HIV, just like we did with Hansen's disease. Hansen's disease also was a vertical management. And now when we look at HIV, so now we're looking at integrating it and making it lateral so that it gets integrated into routine medical care.
Yeah, I agree with you. Thank you.
One of the strategies we have in Singapore is anybody who's applying for some sort of employment pass or an insurance policy has to do an HIV test. So that's it's like it becomes mandatory. Certain passes that you have to apply. For example, you're a foreigner coming to Singapore to work, you have to do an HIV and a chest X-ray for tuberculosis. So that's picked up a lot of disease over the years. And for example, we have a lot of students coming to study in Singapore, young people from the region, and they are required to do a HIV and a chest X-ray for their study pass. To be a student, as a student pass, what are the criteria? So this is one of the ways in which we have managed to keep the situation at bay.
But you don't deny them entry.
Okay.
Because they do that in the Middle East. They do a HIV test, and if you're positive, then you're not allowed to enter their country.
Unfortunately,
so then that becomes, unfortunately, it becomes discrimination.
Unfortunately, it is true. They do that. Unfortunately, it is true. They have done it. Yeah.
Dr. Gori, if you, like some country you wanted to make it like if you're getting married, both couple must produce HIV testing results. If you're negative, you can get married. How true is that?
So in India, when we look at HIV in the community, we actually see that the risk of, the seroprevalence is very low. You have to test at least 500 people before you get that one person who's HIV positive. And in India, unfortunately, in the beginning, that's what happened. Because a lot of men were HIV positive, they got married without testing, and then the women became infected. There was no treatment, the men died. We ended up with a lot of young widows with dependent children who were positive. And that was a kind of catastrophic situation. And this question came into being, like whether we should really do premarital counseling and premarital testing. It's not a guideline, it's advised. If people want to do it, then we definitely encourage them to do it, but it's not a guideline in our country. That's one. And the second is that today we are having HIV positive women marrying HIV negative men. Because with the advent of all these new drugs and an undetectable viral load, you're not going to transmit HIV to your partner. So we have women marrying HIV negative men. And of course, we call the men, we counsel them, we just tell them all about it. And they're very accommodating about it. So, that's a good way to go. When we look at integration, that's a good way to go.
Thank you.
Excellent. If there are no more questions, then we'll call it session to a close. And thank you, Dr. Glory, for that wonderful presentation and update for all of us, especially all of us who are not in this space. Wonderful. Thank you very much. And I hope to see everybody back here again soon.
Thank you.
Thank you so much. For this lovely
Thank
session.
you.
Thank you.
And I
Thank you so
thank
much.
you so much for the speaker. See you again for the next session. Thank you so much.
Bye-bye.